Yes, I'm going to give a talk about diabetes trials, and I also want to touch upon difficulties in clinical trials as well, which we'll get into, because clinical trials are not much different from observational studies in the sense that if it's garbage that you collect, it's also garbage that you get out of it. That's also for clinical trials. We're going to speak about some of the problems there are that you can face. For instance, last observation carried forward. We're going to talk about composite endpoints, which can be a problem. Well, let's get started then. Oh. There we go. Oh yeah, I have a conflict of interest, actually. I hold Novo Nordisk stock, and I have worked for Novo Nordisk as well. So, well, you can hear about it. Well, type 2 diabetes is the issue, or the disease, if it is a disease, that I'm going to talk to you about and give you examples regarding clinical trials. See, the problem is that there's a 2 to 4-fold higher risk of cardiovascular disease within these patients, and that guidelines worldwide focus on the optimization of HbA1c. So the dogma here is to treat the sugar. But no matter how you have tried to treat the sugar, the problem is still heart disease. They die of that. And that has caused some furore, which we'll get into. No trial results have shown cardiovascular risk reduction by glucose lowering. And if you look at this slide, which I think is interesting, then the red bars, they show conventional glycemic control, whereas the blue bars are intensified glycemic control. And this is a paper made by Yudkin, who's been very active in this field. And if you look at coronary heart disease, you see no real difference between intensified glycemic control and conventional glycemic control. Same goes for stroke, blindness, renal dysfunction, all-cause mortality, no difference. But there's a huge difference here in severe hypoglycemia. And that's the problem you see in emergency medicine. I do emergency medicine now, and what we see are elderly people who come in with severe hypoglycemia. And let me put it to you straight, no one benefits from hypoglycemia. It really deteriorates your brain function, doesn't it? So this is what we are up against. Yeah, this is kind of a joke. He died with a perfect HbA1c level. That's, yeah. And why do the companies go for HbA1c? It's a so-called surrogate marker. And surrogates, they need to link to the actual problem for them to be relevant. Blood sugar does not link to cardiovascular disease and type 2 diabetes. But it's, of course, an easy endpoint to measure, and that's why people keep using HbA1c for that purpose. Okay, if you go to the WHO website, you can see that the world prevalence of diabetes in patients over 18 years is 8.5%, and it's increasing. So it's becoming a global problem, and type 2 diabetes is almost reaching epidemic levels in Asia, in Russia, China, many, many places. And the problem there is that people get this condition at a younger age than what we see in the West. And therefore, the problem is that they may have diabetic complications because they have a longer lifespan. So 382 million adults worldwide, and it's projected to rise to more than 592 million by 2035. And what does this mean for the pharmaceutical industry? It means that they have the option to earn a lot of money, doesn't it? Because there are many, many people that will need treatment. Particularly in Asia, we have been into that. And diabetes has become a major cause of death in people younger than 60 years, also because of this age-related problem in the Far East. But following many years of just treating the sugar, something revolutionary actually happened in 2008. The Food and Drug Administration became aware of the problem, or started to focus on the problem that people with type 2 diabetes had heart disease more than others and died of that reason more than others. And therefore, they instigated a new requirement, namely that a novel diabetic drug was not allowed to increase the risk of cardiovascular events by more than 1.8-fold. I mean, that's 80%. You shouldn't think that this was something worthwhile. And you can also see if the upper limit of risk was between 1.3 and 1.8, then further post-marketing trials would be required. It should be noted that data still do not have to show benefit in heart outcomes. With heart outcomes, I mean non-surrogate outcomes, all-cause mortality being the most hard endpoint, of course. And you should note that even here in 2018, 10 years later on, the European Medicine Agency still have not instigated a similar requirement. Has this had an impact upon novel drugs released or developed for diabetes? Yes, it has. You can see here that in 2008, that's when the requirement was established. You can see that the number of cardiovascular trials in diabetes has increased dramatically. This is then projection. So whether you like or think that this requirement was enough or not, it has still resulted in cardiovascular event trials in diabetes never having been more pronounced or common than they are today. So something good came of this. Now let's look at what's up nowadays. There are novel pharmacological approaches that have been approved in the past decade. There are the GLP-1 agonists that stimulate insulin release, and there are the DPP-4 inhibitors that prevent breakdown of GLP-1, so they are linked together. And then there are, of course, the sodium glucose cotransporter inhibitors that prevent reabsorption of glucose in the proximal tubule. They are the novel drugs. So what I want to do now is to look at them, see how beneficial they are, because I'm going to give them a hard time. Of course, that's why I'm here. Actually, this is quite revolutionary. In 2016, in December, there was a label update for EMPA, which was the sodium glucose cotransport inhibitor. Try to look at what the label reads: to reduce the risk of cardiovascular death in adult patients with type 2 diabetes and established cardiovascular disease. What a label! That means the stock will go up here. And that's really revolutionary, something that we've been waiting for a very, very long time. And in August 2017, for Lyra, which is a GLP-1 receptor agonist, they now have a label that reads to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. Revolutionary. So you have two drugs that now should work and address the true problem of type 2 diabetes. Let's look at them. What do they have in common? Well, EMPA was published in the New England Journal of Medicine, and so was the Lyra trial. And interestingly, they have authors in common. A certain Bernard Sinman appears as author of both these studies. So that made me want to look at what's actually going on here. And if you look at the EMPA-REG, which is the EMPA-REG cardiovascular outcome trial, which was for EMPA, and the LEADER trial, which was for Lyra, let's see what they have in common. Look at the study population. They were both older patients with type 2 diabetes at a high cardiovascular risk, both of them. Okay? And treatment was addition to standard of care in both cases. But what's even more amazing is that the number of patients are the same. Randomized patients on trial drug, 4,687 versus 4,668. It's actually the same. It's the same trial. Median observation time, 3.1 years versus 3.8 years. Also very similar. Primary endpoint, completely similar. A composite, cardiovascular death, non-fatal myocardial infarction, non-fatal stroke in both cases. Significant absolute risk reduction, 1.6 versus 1.9. All-cause mortality evaluated, yes, in both cases. Hospitalization for heart failure, yes, he was significant for EMPA and non-significant for LEADER, but both evaluated. And regardless of therapy, cardiovascular death avoidance was 94.1% for EMPA and 94.0% for LYRA. Completely identical. Interesting, isn't it? And and then you can read it yourself. Cardiovascular death standard care group 5.9% versus 6.9, identical. Very interesting. And why is it so interesting? Because they are two completely different drugs. One is a protein that needs to be injected, and the other is a simple, or rather simple, compound that can be taken orally. And nevertheless, same population, same author, same result. So what I've done here is pretty nasty, because when these trials come out, they report relative differences, not absolute differences. And the relative differences are significant in the cases I'm going to show you, and reach a level of between 15 and 20%. But if you look at the absolute differences between treatment groups, then you'll see that the absolute difference is minute. Here, EMPA, that's EMPA added to standard of care, high-risk diabetes. The standard care group had a cardiovascular death of 5.9%. If you give them EMPA, 2.2% avoid cardiovascular death. 2.2%, okay? And 3.7% die regardless of therapy. And in 94.1%, no cardiovascular death regardless of therapy. And a number needed to treat of 46. So this is the benefit you get. So on one hand, you can say, thank God, finally the problem with type 2 diabetes is being addressed, namely cardiovascular death. But, I mean, it's not something to be, that's amazingly significant or of major impact. And it's a expensive drug, particularly in low-income countries. That could be a problem. So I'm going to go to cardiovascular death with LYRA as well. You see numbers practically the same, 6.1, 6.0 suffer cardiovascular death. The benefit of LYRA, 1.3%, 1.3%. 4.7 die regardless of therapy, and 94% no cardiovascular death regardless of therapy. Number needed to treat 77 patients. Not impressive. All-cause mortality, EMPA, 8.3% die. The benefit, 2.6% avoid dying. Yeah. 5.7% die regardless of therapy, and number needs to treat 39 patients. Again, I would say not impressive. All-cause mortality for LYRA, well, the figures are practically identical. No reason to read them out for you, being pressed for time. Identical. Hospitalization for heart failure, EMPA was added to standard of care. 4.1% hospitalized, 1.4% avoid hospitalization. Yeah. So, and there was no effect on hospitalization for LYRA. So, is this an essential medication? What do you think? Is it essential? Is this important? You think it's important? Yeah, but there are certain things you can say it's a composite endpoint. The composite endpoint, however, is rather strong. Composite endpoint can be very weak if one of the composite endpoints is a weak endpoint. For instance, unstable angina is a typical example of that in cardiovascular disease. But not a major benefit, 2% in the range of that. So What one can do here to establish whether it's an essential medical medication or not is that the WHO, they actually issue, each year they issue a list of drugs that they consider essential. And EMPA and LYRA are not on that list. They want more trials before that's going to be, that list will be enlarged with those two drugs. So, are these trials a home run for science? Well, excellent that they address the problem. Results, not impressive. For industry, absolutely. These two drugs are on the run, and they're going to earn a lot of money on this. Then you could talk about social issues in low-income states where that would not be so appropriate. But of course, the medical industry is here to earn money and here to develop new drugs. I'm just giving you the hard data. So then there's another drug coming up. It's semaglutide, which is also a GLP-1 drug. And the FDA has approved it, indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. The problem was that semaglutide had no effect on cardiovascular outcomes. It did have an effect, however. Well, let's just take it as a composite endpoint. The usual that you know from EMPA and LYRA, 3,297 patients, 1.9 years. The others were 3 years, so this is a smaller trial. They have an absolute risk reduction of 2.3%, which was not significant in the cardiovascular, but it was for stroke. I'll show you the data. Here you see non-fatal stroke added to the standard of care. It had an avoidance rate of 1.1. Also not impressive. But this drug is novel because you only need to take it once weekly. Anyway, those are the data. So we have talked about it already. I would say watch out with composite endpoints. A higher number of events is expected during the trial. That's why you use composite endpoints, so that the trial can be over with within a certain acceptable time frame, because it costs a lot of money, of course, to develop these drugs. However, I would caution if one of the endpoints is soft, and I mentioned angina as one of them. So the more hard the composite endpoint is, the better. So what do we need in the future? Well, I still think that we need more quality by trial design. We need to look at clinical outcomes, patient-relevant clinical outcomes, not surrogates as the primary endpoints. We need to enroll patients in real-world settings across different countries, because these trials run in the West. We need to do these trials in the East as well, the Far East. Long-term follow-up is missing. And I would say to motivate countries to invest in long-term trials, you could give them certain financial incentives, such as offering a longer patent life. At least that could be considered. However, I also think that there are other roads to lead to the goal. I don't think that type 2 diabetes can be controlled until its major predisposing risk factor, which is obesity, is addressed. And hampering this effort is the widely held attitude that obesity is not a problem it's just a problem for individuals. It actually isn't. It's for a whole society. Are we running out of time? There's one last point I'd like to make. Basil actually was so kind to forward to me a new definition of diabetes. Now, recently published in the Lancet Diabetology and Endocrinology, diabetes is broken down into 5 categories. But way before that, actually, back in 2013, another rather famous diabetologist, Edward Gale from Bristol, wrote the following in The Lancet. Is type 2 diabetes a category error? And what does he mean by that? Well, he says that a category error occurs when we assign a problem to a category inappropriate to its solution. And by that, he means high blood sugar. Because treating the high blood sugar does not reduce the cardiovascular events which these patients die of. So actually, it could be a category error. And you could say there's no doubt that type 1 diabetes is a dangerous disease, and it endangers your life. It's life-threatening if you're not treated with insulin. That's not the case with type 2 diabetes, in which companies try to promote the use of, for instance, analog insulins at a high price. So instead of calling it type 2 diabetes, you should get rid of the word diabetes for type 2 cases and call it idiopathic hyperglycemia. And his point is that it's hardly a disease in its own right, because the unitary disease concept has failed to achieve satisfactory management of this condition and its associated risks. And type 2 diabetes could be perceived as an outcome of network processes contributing to an affluent phenotype as obese. Adiposity, hypertension, hyperglycemia, hyperlipidemia, cardiovascular disease, and cancer, actually. So this affluent phenotype should be viewed in dynamic rather than static terms, and as an adaptation rather than a disease. And I think this is thought-provoking. And with that, I think I have come to my conclusion. Thank you very much for your time. I'd be very happy to answer some questions if you have some. Do you think I've been provocative? Many people do not like this talk from the industry, I must say. But I am not against industry. I work every day as a physician, and I would say without the products that medical industry deliver, how would I be able to treat my patients? But I do think that industry has a problem when they promote drugs, for instance, analog insulins, at a higher price with no additional benefit. That, I think, is so-so.
Thank you for the presentation.
My pleasure.
Yeah, of recent, I was in a discussion with someone. It's still not clear to me. What is the place of insulin? Does it have any influence on cardiovascular mortality in patients with diabetes? Insulin therapy.
Well, there are indications showing that insulin is not beneficial, that it actually could promote cardiovascular disease. And you see that the drugs that have been shown to show some benefit, although small, are not insulin products.
Okay.
So, and of course, you know, insulin is actually an anabolic, has anabolic properties. And one could consider if it promotes atherosclerosis.
Then you're just like the introduction, the suggested new definition for type 2 diabetes. With our understanding of the pathophysiology or the pathogenesis, at the time, they start with maybe they could tolerate oral hypoglycemic agents.
Yeah,
But
yeah.
at the other end, the fact that you cannot achieve good glycemic control without insulin. So what happens with this new classification?
I would say that, you know, people have to shape up. They have to lose weight. And that's painful. I know. Look at me. I mean, I need to lose weight too. But I mean, that's painful. But it's something you can do yourself, and it's not costly. And it promotes all the parameters. It's beneficial for all the parameters that we look at: hyperlipidemia, hyperglycemia, hypertension, etc. So that's a place one could start. What people want, what patients want, are easy solutions. They want to go to the doctor and say, look, I have this problem, fix it now. And you take a drug and you're good. But that's not the way the world is, I'm afraid.
Thank you.
My pleasure.
I think I have a question. Thank you very much for such an important presentation about the topic that's a really global problem, type 2 diabetes. I want a little bit to understand and clarify those two trials that you were showing us about standard therapy. If it was supposed that it was metformin or there was a difference between standard and CGLT2 and standard, what was that?
What the difference was?
No, what was standard?
What was
therapy?
standard? What was,
Yep.
yeah, what was standard? That you have to go into the paper to read that.
Maybe you know.
I don't know that by heart. I'm sorry, I really don't. But it was standard therapy, including analog insulins.
It was
Including,
added, but
including,
I
yeah.
was wondering
It was
what was
it was state of the art therapy. Yes.
Okay,
Yeah.
thank you very much.
Yeah.
I can comment on that. I have a declaration of interest as well. I'm employed for Novo Nordisk. I heard your talk before, and I think it's important that this. It's an important discussion. Standard care treatment was within hypertension and the lipidemia, and was also the investigators were asked to treat the glycemia as well, and could add on medication to that, including insulin. So it was on top on standard of care. So the other risk factors were supposed to be treated as well.
Yes. Yeah.
And what we saw in the LEADER trial, I can only talk for the LEADER trial, was that there were a difference in anti-diabetic treatment that was added to the placebo group compared to the... in the placebo group, you could add on any drugs except for other GLP-1 agonists. So you could add on insulin, DPP-4s, TCDs, sulfonylureas, but they were already on metformin treatment. They were the included population were on metformin treatment before.
And there was, of course, a limit to the HbA1c level for inclusion and so forth.
Yeah,
so,
the inclusion, there was a lower limit. Actually, in the LEADER trial, there was no upper limit. So the inclusion HbA was above 8, actually. Yeah, there were a high-risk population who were included in the LEADER trial. And also the EMPIRIC trial.
Yes?
Thank you. I just think this highlights very well the challenges in doing trials in diabetics right now, because what's happening out there, and I think we all need to think about that. I'm involved in the DECLARE study, which is going to be closing out in May, June, July this year on, I think, 17,000 patients. So what's happening in DECLARE now? What is the standard treatment? Because as an investigator and as a site, we're suddenly faced with new data. So here's the scenario. You're doing the study, and exactly what you said, all things fine. But about 2 years ago, I think, when did EMPIRIC come out?
Yeah, that's about 2 years.
Something like that. All of a sudden, the whole world's talking about, but, I mean, you know, you're doing a study on a glyphosate SGLT2 inhibitor, now we know, well, we think we don't know, now we've heard the results. And at the same time comes out the LEADER trial with the GLP-1 analog. And so what happens is now, I think you will find when you look at the standard care in the DECLARE study, you will find that a lot of people, now you're not allowed to give another SGLT inhibitor, but you will find a lot of people in that trial are now getting liraglutide as part of what's called the standard care to control the diabetes, because people think it's a good drug to use. So I think it makes it very confusing in planning trials and analyze them. I actually suggested to the TIMI group who we're doing the study with, you should make them immediately go back to the baseline data and see where we stand with liraglutide and GLP-1 analogs, and see if there's just do some dummy analysis. We don't know who's getting what, but let's just see where we are, and they should be prepared in how to analyze the data when they come out later this year. So I hope I think it's going to be very interesting.
It's going to be interesting.
Challenging.
But it's a very difficult subject, and it's a very important subject because of the epidemic proportions of the disease.
It would have been interesting if those two trials which was incredibly well presented. Thomas, congratulate you.
Thank you.
Now, I don't think anybody actually pointed that out other than you. It would have been interesting if they would have done it as a 2x2 factorial design, and you could have had GLP-1, see, combined therapy. It's amazing what would happen if you combine this. Do you get a more benefit or do you not?
So the only chance that we have to reduce the cardiovascular death in such a patient is metformin. How should we titrate it? That's my question. And a second question is, what's about the setting of acute hyperglycemia in acute coronary syndrome? Should we treat or not?
Excellent questions. As for how you need to titrate the drug, it's my point of view that this disease, you need to look at the individual patient, in my view, to be updated 100%. Because I think there's a huge difference between being 35 years old and having this condition and being 75 years old or 80 and having this condition. Because there are different aspects of life that are important to these people. For instance, the older person maybe enjoys cupcakes or chocolate, what do I know? That's that person's pleasure in life, you can say. Whereas, and that I think then should be allowed. The point I was trying to make with hypoglycemia is that that's just to look at an elderly patient and go after the guidelines and say, listen, I want the HbA1c to be this and that. That ruins their lives and they accomplish nothing. So I think you need to titrate according to the individual. And as for intensive hypoglycemic control in acute coronary conditions, I think that the data indicate that that's even dangerous. Yeah. But thank you for your interest, for sure.